Hello, everyone, and welcome to today's webinar on proactive pediatric inflammatory bowel disease testing. I'm Delta Lane, the Senior Product Manager for the Gastroenterology Division for Mayo Clinic Laboratories. Our presenter today is Ann Moyer, MD, PhD, who is a molecular genetic pathologist at Mayo Clinic in Rochester, Minnesota. She holds the academic rank of Associate Professor of Laboratory Medicine and Pathology, as well as Assistant Professor of Pharmacology. Dr. Moyer, thank you for joining us today. Just a couple things to remind everyone before we begin. There will be a question and answer session at the end of the program where you can submit questions online via the Q&A function, or you can raise your hand to receive access to speak. And now I'll turn it over to our presenter, Dr. Moyer, who will give a brief introduction on her background before she begins her slides.
Thanks, Delta. As Delta mentioned, I am Ann Moyer. I am a molecular genetic pathologist at Mayo Clinic, and I'm lucky enough to have done all of my training here at Mayo in the MD PhD program, and then followed that by an anatomic and clinical pathology residency with a year of research, and then followed that by a molecular genetic pathology fellowship, and then started on staff. My main areas of expertise and interest are in pharmacogenomics, which deals with understanding how different patients might respond to different medications based on their genetic background, as well as hereditary genetic disorders, which would include some of the pediatric inflammatory bowel diseases that we'll be talking about today. So I wanted to jump in right away and tell you a little bit more about pediatric inflammatory bowel disease. And since I am a molecular genetic pathologist, I'll be mostly focusing on some of the genetic tests that we have available, but I'll touch on a few of the other tests as well. And hopefully we'll have plenty of time for questions and answers. So our learning objectives today, I think, have been sent out in advance, but we're going to talk about some of the testing opportunities before you started a patient on thiopurine therapy, while they're already on it, and then some of the things that you might want to think about for patients in addition to thiopurine therapies, particularly young patients. We'll talk a little bit specifically about how enzyme and genotype testing can be used together to assess the risk of patients before you started them on a thiopurine therapy. And then the part that I'm really excited about, we're going to also be talking about how you might be able to identify some underlying genetic causes of illness, specifically inflammatory bowel disease in children, and how you might want to use that information to clarify and confirm the diagnosis, and especially to guide treatment choices. So one thing to know about pediatric inflammatory bowel disease is this is a fairly common disorder. So on the whole, about 3 million Americans have inflammatory bowel disease, and about a quarter of them will actually develop this during childhood or adolescence. Interestingly, the age of incidence is decreasing, so younger and younger patients are presenting with inflammatory bowel disease, and overall the disorder is becoming more frequent. Of the subset of inflammatory bowel disease that is something we see in young children, we'll talk more about terminology in a couple of minutes here, but very early onset inflammatory bowel disease makes up about 15% of pediatric inflammatory bowel disease. And of those patients, some of them may have an inherited primary immunodeficiency disorder or another genetic condition, and therefore genetic testing is an important approach to help identifying these patients so that you can get them on the most appropriate therapy. So when you're thinking about inflammatory bowel diseases in general, we're talking mostly about ulcerative colitis and Crohn's disease. But in addition, there are a number of patients, especially in the pediatric population, where they might have something that you might call inflammatory bowel disease unspecified. So there are some overlapping features, and it's a little bit hard to know for sure, is it really ulcerative colitis, or is it really Crohn's disease, or is it maybe something actually entirely different? And that's what we'll get to towards the end. So many of the symptoms would include diarrhea, often bloody, rectal bleeding, abdominal pain, fatigue, and weight loss. And these are pretty similar symptoms that you might see in adults and children. But another feature that you might see in children is that they may have a failure to thrive or difficulty gaining weight and growing normally. So overall, these disorders can be quite debilitating, and in some cases can even lead to life-threatening complications. So it's really important to get the right diagnosis and to get the right treatment for these patients. Something that's interesting about inflammatory bowel disease is that basically the primary feature is this chronic intestinal inflammation, but there are a lot of different reasons that this happens, and it's probably not just one reason, but all of these reasons together. So patients may have an underlying genetic susceptibility, microbial imbalance, dysregulated immune response, and then also some environmental triggers. And so thinking about all of these pieces together is how you can get to the point where you can diagnose and treat inflammatory bowel disease. And even though each of these are interesting in and of themselves, especially the genetic susceptibility, which is my favorite part, we can't forget that all of these other pieces are also important. If you think about genetics and inflammatory bowel disease, there's probably a spectrum. So if you've got younger patients that you're seeing, it's more likely that they might have some rare genetic variants in some of these monogenic forms of IBD that we'll talk about later, versus the bulk of patients with IBD actually have what we would call a polygenic form. So they might have multiple common genetic variants that are all contributing along with the environment and the microbial milieu, and then that dysregulated immune system. And so this is where most of the patients who present in adulthood would fall, and probably actually quite a few of the patients even that are presenting in childhood. So we're going to talk a little bit about the treatment of this first, and then later towards the end of the time, we'll talk about those rare variants and monogenic forms. So again, most IBD is probably led to by common genetic variants, polygenic forms, and there are a lot of different types of therapies that can be used. So we'll consider this the conventional IBD because, again, this is the most common. And when I think about IBD, this is what I think about. So the goal in this case is to reduce inflammation. And if we can get the inflammation reduced, then that should lead to symptom relief and hopefully reduce the risk of long-term complications for these patients. Usually a multi-pronged approach can be utilized. There are anti-inflammatory drugs, including aminosalicylates and corticosteroids that are often used to get the disease under control. But then you may have heard of a lot of these emerging biologic drugs. These are really exciting because more of them keep getting developed and added to the arsenal to be used for IBD. And you can see a number of them listed here. But then we also have the immune system suppressors, including thiopurines and methotrexate. And thiopurines are what we'll be talking about first here today. But one thing to note about thiopurines is they can require up to 3 months to achieve therapeutic benefit. So they're usually not used upfront for induction of getting to that anti-inflammatory response, but a little bit later in the duration of therapy. But something that I think is really quite exciting too is some of these drugs can be used alone, but in other cases, they're used in combination. So even though our thiopurine medications have been around for a long time, and now we've got these new exciting biologics, the thiopurines are still used. So let's talk a little bit more about thiopurines. So thiopurines are actually medications, and structures shown here on the right, and they mimic the structure of purines, which are shown down here on the bottom, that are used in DNA and RNA synthesis. So if you remember back to some basic biochemistry classes, you might remember the purines, so adenine and guanine that can get incorporated into DNA and RNA. And if you look at these structures up here, they look awfully similar, except there tends to be a sulfur group added in. And so these can result in cytotoxicity and immunosuppression. And that's the goal here, is we want to suppress the immune system to decrease the effects of the inflammation on the GI system and get our IBD under control. They are really important because a lot of the patients will end up on a steroid as their anti-inflammatory, but long-term, you really don't want to keep a patient on a steroid. So the thiopurines can be used for that long-term remission and hopefully be able to avoid the long-term use of steroids. And as I mentioned a minute ago, at this point in time, these are pretty old drugs. They've been around since 1950s, 1960s. And at this point in time, though, the thing that's newer and exciting about them is that we can better predict the toxicity. And we've got therapeutic drug monitoring strategies that we didn't have historically. So that makes these drugs that are relatively old cost effective because they're not something that we just came up with recently. But at the same time, they can also be a lot safer than they historically were before we had these tools. And one of the things that I think is really exciting about the thiopurines is, again, they can still be used today because sometimes they're thought to be able to control the immunogenicity of biologic therapies. So definitely still relevant. So let's talk a little bit more about thiopurine metabolism. So azathioprine will be converted into 6-mercaptopurine, and these can both be used actually as drugs. And then here's our thioguanine over here. And the 6-mercaptopurine will be metabolized through a series of steps into the 6-thioguanine nucleotides, which are shown here. And it's actually, there's monophosphate forms, and there are triphosphate forms and diphosphate forms as well that aren't shown on our diagram. and they can be deoxy forms or just the regular forms. And together, even though there are these 4 different boxes that I'm showing here, this is what we call the 6-thioguanine nucleotides. And that's the active metabolite of the thiopurines, and that's what's going to result in our cytotoxicity and immunosuppression. But you'll notice that in addition to this pathway to get to our 6-thioguanine nucleotides, there's some other pathways off to the side where 6-mercaptopurine can be detoxified into other metabolites. So specifically one that we're going to be focusing on right now is this arm of the pathway where we're going to methyl mercaptopurine, and that reaction is catalyzed by TPMT. And over here you can see something similar with our thioguanine as well. So with the thiopurines, one of the things that's really limited the ability to use them historically was some of these adverse reactions. So especially the myelotoxicity, but also hepatotoxicity, pancreatitis, GI problems, and vomiting. And so these are some things that were really worrisome, and especially, like I mentioned, the myelotoxicity, which is something we can actually predict reasonably well now. So thiopurine methyltransferase, again shown here and here, is a very polymorphic enzyme. And what I mean by that is, for those of us that like pharmacogenomics, it's a really fun enzyme to study because different individuals have genetic variants that impact the activity of this enzyme. So approximately 87.3% of Caucasians have normal TPMT activity. And in theory, you should be able to give them a standard dose of their thiopurine drug, and hopefully everything will go well. Although, just to keep in mind, even though I really, really like genetics, there's a lot of other variables that are also at play when we're talking about drug metabolism that we really can't totally forget about. So we're going to be focused on the genetics, but again, clinical correlation is always really important. Now, in addition to those 87.3% of Caucasians, though, about 12.4% are intermediate metabolizers. And what I mean by that is they have a genetic variant impacting one of the 2 copies of TPMT that they inherited from their parents. And so one copy is working fantastically and the other copy is non-functional. So that means that their enzyme activity ends up being lower than you would expect. And so instead of having a lot of this 6-mercaptopurine going down this pathway to be detoxified, more of it will go down the pathway to form those 6-thioguanine nucleotides that are active. So these patients might end up having a little bit higher risk of toxicity if they're given a standard dose. And then we have 0.3% of Caucasians have absolutely no TPMT enzyme activity. So both copies of their gene were impacted with genetic variants that made it so that the enzyme would be non-functional, and therefore they can't use this arm of the pathway at all. So more of their 6-mercaptopurine will go down the pathway towards making these reactive metabolites, which is good to treat disease, but if you have too much of these, that's where you can run into some of the toxicity issues, especially the myelosuppression. So again, patients with reduced or no TPMT activity, they can benefit from a dose reduction of the medications azathioprine, 6-mercaptopurine, or thioguanine, so that then they can hopefully avoid the myelosuppression. And so there's an FDA label as well as some guidelines explain how you might want to dose these patients if you know that they have reduced TPMT activity. And patients can have increased TPMT activity as well. And as you can imagine, with increased TPMT activity, more of the 6-mercaptopurine is going to go down this pathway, and they'll end up with more of the methyl mercaptopurine. And this may actually increase their risk for hepatotoxicity. Now, there's something really exciting that we learned about not that many years ago. So NUDT15 is another enzyme shown here in the pathway, and it's also an important component of thiopurine metabolism in that it will take the triphosphate forms of the 6-thioguanine nucleotides, which is the form that can actually be incorporated into DNA and RNA, and it will remove phosphates so that we end up back with these monophosphates that can't be incorporated. So this basically is somewhat detoxifying the thiopurines as well. And so some very similar things will happen if you have reduced NUDT15 activity. So they actually just found this in a genome-wide association study back in about 2014, and they were trying to understand why patients of Asian descent seem to be at increased risk of toxicity despite having fewer, or the TPMT variants being more rare in that population. And so they were looking for other genetic variants that might predict toxicity when using thiopurines, and that's when NUDT15 really emerged as being part of this pathway and something that's really important. So now the US FDA label recommends dosage adjustments for patients with both TPMT and or NUDT15 variants. And I thought this was really exciting because we were able to incorporate NUDT15 into our testing only a couple of years later. And so this is really quick translation from bench to bedside. So NUDT15 is definitely an exciting development in thiopurine metabolism. So just to look at that a little bit more, I wanted to give you a snapshot of how common these genetic variants are in TPMT and NUDT15. So what you're seeing on the screen here is a lot of data that comes from a public database called NOMAD, which includes 123,136 exome sequences and 15,496 whole genome sequences from unrelated individuals who were sequenced as part of various disease-specific and population genetic studies. And so basically, this shows you how common the genetic variants are in terms of the actual allele frequency. So remember, each individual will have 2 alleles, 1 from each parent, and this is showing you how frequent these alleles are. And so one thing I wanted to point out is we've got TPMT on the top, we've got a variety of different populations in the columns, and NUDT15 down here. And as you can see, the NUDT15 variants are really quite common in East Asian and South Asian populations where this gene was originally identified as being part of the thiopurine pathway, but also in Latino and in mixed American populations as well. And if you compare this to some of the frequency numbers for TPMT above, you can see that NUDT15 is really quite important. It's far more frequent to find an NUDT15 variant in the East Asian population than the TPMT variants in any of the populations. But if we're only testing for TPMT and we're not including NUDT15, we might actually be introducing some healthcare disparities, and there are a lot of patients who would be at risk of toxicity that we wouldn't be able to identify. But one thing to note is even for populations that are primarily of European descent, which are shown in the 2 columns highlighted in purple here, NUDT15 variants can be encountered. And when we find these variants in patients of European descent also, they are still clinically relevant just the same. So there's not really any downside to testing for NUDT15 because we can see these variants in pretty much all populations that we look at. So I think this is one of the big take-home messages that I want everybody to get, is if you're prescribing thiopurines and you've been thinking about TPMT for quite a few years now, well, don't forget about NUDT15. It's the new gene that we're thinking about now, but extremely important. So if you're planning on starting a thiopurine in a patient with inflammatory bowel disease, here's kind of the pathway to think through. So you're thinking about initiating this therapy. Well, you've got a couple of testing options. There's a TPMT activity assay, and then there's a TPMT and NUDT15 genotyping test. And then based on the results of these tests, you can select the best dose for the patient and begin therapy. And in some cases, maybe you'll realize at this point that a different therapy would be better than a thiopurine, but these tests can be useful for both of those. So when should the enzyme activity assay be used? And when should the genetic test be used? This is definitely a common question that comes up pretty frequently. So I wanted to tell you a little bit more about these 2 tests, and then I'll answer that question. So here you see that same pathway, except I collapsed the 6-thioguanine nucleotides into one box here just to simplify. But basically the TPMT3, which is the name of the activity assay that we have available at Mayo Clinic Laboratories, measures TPMT in 3 separate reactions. We've got the 6-mercaptopurine to the 6-methylmercaptopurine that we were talking about on the previous diagram, but also we have 2 additional reactions. And the measurements all occur in red blood cells or erythrocytes via LC-MS-MS. The TPMT activity ends up being reported as nanomoles of product per milliliter of packed red blood cells per hour. And due to the approach used for the chemistry and analysis, TPMT3 can actually reduce the clinical uncertainty or the indeterminate results that you might get from other TPMT enzyme activity assays. So one thing that I think is really exciting about this is you're directly measuring this activity by looking at these products and knowing how much of each of the analytes was put into the assay. So whether the TPMT activity is normal, increased, or decreased, even due to rare genetic variants, that could be detected with this assay. In contrast, here is the genetic test. And in this case, we're testing for specific genetic variants using a PCR-based approach. It's also called a TACMAN assay. And if anyone's really curious about how the chemistry works, definitely happy to talk about that at any time. But in one assay, we're looking for variants in both TPMT and NUDT15. And you can see the star alleles that are listed here. And so those are the specific genetic variants that we're looking for. And in the end, we'll end up classifying the results based on the predicted phenotype for each gene. So the patients could be classified as a normal metabolizer, an intermediate metabolizer, or a poor metabolizer. And in this case, because we're looking for genetic variants, we can accept a blood specimen, or we could use a saliva specimen. And I think especially when you're talking about a pediatric population, sometimes a saliva specimen might be a little bit more attractive in those cases. So again, genetic variants in both genes will be resulted out with one test. So when do you decide? How do you know? Do I use the enzyme test or do I use the genetic test? Well, at the end of the day, for both of the tests, the TPMT results are pretty much going to be comparable. And so the enzyme activity test, one of the things it could pick up is rare genetic variants that are impacting TPMT activity that would be missed by the genetic test because we're only testing for a select subset of genetic variants. But again, these are pretty rare variants, so I wouldn't expect them to be common in very many patients, but that would definitely be one advantage of the enzyme activity test. And then also the enzyme activity test can detect hyperactive TPMT metabolizers. And I would love to include this in the genetic test, but we're not entirely sure what the genetic correlate of the hyperactive TPMT activity is quite yet. So maybe sometime in the future. The genetic correlate, as I mentioned, is unknown, but we'll see. Maybe someday we'll be able to add that in. But the exciting thing about the genetic test is, again, for NUDT15, it will be included in your genetic test result. And at this point in time, we don't have an enzyme activity assay for NUDT15. So for getting comprehensive testing of both TPMT and NUDT15 together, you'd really need to do the genetic test. But again, you won't be able to detect the hyperactive metabolizers. And if a patient has a very rare genetic variant in TPMT, we would not pick up that with the genetic test. So it would be best to be able to use both tests together if that's an option. And a few other considerations to think about. If a patient has had a recent red blood cell transfusion, that could be an issue for the enzyme activity test, because remember, you're testing the enzyme activity in the red blood cells. And if those red blood cells don't belong to the patient, it will not reflect the metabolism that would occur in that patient's liver. They're also, because of it being red blood cells that the enzyme activity is being measured in, it can be impacted by altered hematopoiesis and also uremia. But on the flip side, if a patient had a recent red blood cell transfusion, for the genetic test, you'd have to consider the potential presence of donor DNA. So it'd be good to know, did the patient receive a leukoreduced red blood cell product? How many red blood cells did they receive? Things like that. But this is definitely something that we could help you think through in the laboratory if you gave us a call with a question like this. Also, if a patient has had a bone marrow transplant, this can be similarly an issue for both of these tests, in that, again, the red blood cells would be coming from the donor, and most of the TPMT activity and the NUDT15 activity is in the patient's liver. So in those cases, we would end up wanting to get a pre-transplant DNA specimen or germline DNA from another tissue. So again, something that's a little more complicated, and if you run into this situation with a patient, it's best just to call us in the lab and we'd be happy to work through it. The enzyme activity assay can also be impacted by other medications that the patient might be taking. So that's another caveat to think about. So the bottom line, if you can do both tests, that's the best. If you can only do one of the tests, the genetic test does include both of these genes. And I think that's important to consider, especially when we know how common these genetic variants are in NUDT15 across many populations. So I wanted to show you what these reports might look like. If you ordered the TPMT3 enzyme activity assay, again, this will just give you results for TPMT. And you can see the results for each of the various metabolites that were tested, and a reference range is also provided. It also comes along with an interpretation, and the first word of the interpretation is also something that will be corresponding to what you would see on a genetic test result, slightly different terminology, but it will help you know how to manage the patient. So here the word would be heterozygote, which would correspond to an intermediate metabolizer in the genetic test. And here's what the genetic test looks like. So again, you will get TPMT and NUDT15 together. And the TPMT portion should correlate with the TPMT3 activity assay. So in this case, this patient is an intermediate metabolizer, which is the same as heterozygote in the other case. And the NUDT15 genotype and phenotype, which is only available as part of TPNUQ. And then at the bottom here, you can see that there's an interpretation, and it ties together the results of both TPMT and NUDT15 together. So basically, if the patient has reduced metabolism of either of these, a dose reduction would probably be most appropriate to consider. And if they have genetic variants in both of them, it's very similar to being a poor metabolizer of either of the two enzymes. And so another resource that's really helpful is the Clinical Pharmacogenetics Implementation Consortium, or CPIC, has a guideline for thiopurine dosing based on TPMT and NUDT15 genotypes. And so this is another place where it walks through some decision trees about how you would dose a patient if you had these variants present. So what about metabolite monitoring? So this is something else that's new and exciting that can help with thiopurines. And so this would be something that occurs after the patient has started the therapy. So TPMT3 and the TPNUQ testing you would do before you start the patient on therapy, and then metabolite monitoring can happen later. So I'll speak a little bit to this. This test is called Thio is the code, and it's useful for guiding dose adjustments, minimizing dose-dependent toxicity, and monitoring compliance. And how this test works is it is measuring the levels of 6-methylmercaptopurine and collectively the 6-thioguanine nucleotides. And so it'll be reported out as picomoles per 8 times 10 to the 8th red blood cells of 6-thioguanine and the 6-MMP derivative analytes. So you get both results on the report. And the recommended time points for doing this testing would be about 4 weeks after starting the thiopurine therapy. And at this point, you could both verify compliance as well as start to evaluate for early risk of toxicity. And then again, at 12 to 16 weeks after starting, the 6-thioguanine nucleotides, again, the reactive form of the thiopurines, will have hopefully by then reached their steady state. And so you can get a sense of how that patient's metabolism looks. And then thereafter, you'd want to perform this annually just to make sure that you're not seeing any signs of toxicity, as other variables may have changed throughout the patient's lifetime. In addition, this test can be used as needed. So if the patient is not responding as expected, if they've had a dose change or a flare-up, or starting to see some signs of toxicity. So one thing to note, the TPNUQ test and the TPMT3 test, you really only need to do those ones once, because those are upfront before you start putting the patient on therapy. And from a genetic standpoint, hopefully their genes don't change over time. For the most part, once you've performed that test, you should be good for these patients, unless we've drastically improved the test. But if the patient's already on a nice dose that's working well for them, it wouldn't be something to worry about at that point in time. The Thio test, on the other hand, you may want to, or you would want to measure repeatedly. So this would be a test that you don't order just once, but you order multiple times throughout the patient's lifetime while they're on thiopurines. So a couple of things to note about the thiopurine metabolite monitoring assay. If you've got high levels of 6-methylmercaptopurine, this might suggest an increased risk for hepatotoxicity. And remember, this would correspond to those patients that had the TPMT hypermethylation that could be detected by the TPMT3 assay. In addition, you'd need to use this test with caution in individuals with NUDT15 variants, because the 6-thioguanine nucleotides are measured collectively. But remember, NUDT15 will be taking the triphosphates and converting them back to the monophosphate forms. So just something to keep in mind, that this is something we can't measure right now. And these reports also will show you the level of the 6-thioguanine nucleotides and the 6-methylmercaptopurine. And if your patient had a higher level than expected or lower level, you'd see a little caution flag, and it tells you which direction. And again, this is something that if you had questions about it, the lab is always happy to answer questions. There are many, many other tests available through Mayo Clinic Laboratories for inflammatory bowel disease. And since I mostly focus on molecular genetic pathology, these are out of scope for today's talk. But if you're interested in learning more about them, please contact Mayo Clinic Laboratories for questions and for further discussion. We've really got a really nice, complete test menu to help out with inflammatory bowel disease, both for diagnosis and following patients over time. So back to thinking about genetics and inflammatory bowel disease again. We talked about these common variants and using thiopurines, particularly in that population. So let's look a little bit more at these rare variants and the monogenic forms of IBD. So the classification of pediatric IBD can be divided up based on age. And so if patients are younger than 17, sometimes this is referred to as pediatric onset IBD. If they're younger than 10, this is sometimes called early onset inflammatory bowel disease. And then if they're younger than 6, this can all together be classified as very early onset IBD, or you might see VEO IBD. And then some people will further subdivide those that are younger than 2 as infantile, and within the first 28 days of life as neonatal IBD. So although some patients with very early onset IBD do have underlying monogenic etiologies, such as immunodeficiencies, the majority of them will still not have a specific identified causal genetic etiology. And this might be in part because we don't know all of the genes involved yet, or it could be that some of these really do have that polygenic form, just like you might see more commonly in adults. So with very early onset IBD, there tends to be a higher rate of an IBD that's unclassified as compared with adult patients. A positive family history is more likely in these cases, and this further supports an increased genetic contribution. And there are a number of different categories of etiology. So there could be just general immune dysregulation, specific T cell or B cell defects, phagocyte defects, hyper and autoinflammatory conditions that we're learning more about these every day as well, epithelial barrier dysfunction, and a number of different other conditions. So a lot of these fall within the category of immunodeficiencies, but again, there are some other types of genetic defects that can also lead to very early onset inflammatory bowel disease. And some studies have suggested that patients with very early onset IBD may be resistant to conventional therapy. So if you're seeing patients who aren't responding how you would expect to that thiopurine or some of those biologics, those might be patients to think about, these monogenic causes, and especially very early onset IBD. Multidisciplinary approaches, including a comprehensive immune evaluation, are very important in directing management for these patients. So the other things to think about is they tend to have a more severe phenotype, and especially the patients that are presenting at age 6 and under, they're going to be living with the disease for many more years, even if a monogenic cause isn't identified. And so they tend to have a higher rate of surgical interventions, a higher rate of extraintestinal manifestations, a higher failure rate of the TNF inhibitors, and they may have growth failure due to compromised nutrition and chronic inflammation. So this is a little bit different than you might see in adulthood when these patients are presenting earlier. There also tends to be a little bit higher male to female ratio in patients with very early onset IBD. So for the monogenic causes, it's really important to identify the genetic etiology, because if that can be identified, sometimes this can enable using a more targeted therapy, and that might be more successful to get the patient's disease process under control. Also, it may help avoid harmful or ineffective therapies and get them onto the right treatment a little bit sooner. So a few examples of this, and this is not going to be a comprehensive list, but there is a drug called abatacept that can be useful if a patient has a CTLA-4 or an LRBA deficiency. Anakinra can be used for patients with IL-10 signaling defects, or chronic granulomatous disease, or mevalonate kinase deficiency, or MKD. Colchicine can be useful in patients that actually have familial Mediterranean fever, which could present similar to inflammatory bowel disease. Also, for patients with chronic granulomatous disease, you might want to avoid an anti-TNF therapy because there are some concerns about disseminated severe infections in patients with CGD who are treated with these therapies. And also, for a number of these monogenic disorders, a hematopoietic stem cell transplantation may be curative. But it's important, again, to know the specific genetic change, because some patients may have both immune and epithelial defects. And in those cases, the hematopoietic stem cell transplantation can be really helpful with the immune component, but not so much with the epithelial defects. So if you're trying to think about, well, who should we be testing for these monogenic disorders? an acronym that's really quite useful is young age matters most. So definitely young age onset would be something that would be a key variable to be looking at, because the younger the patient, the more likely they are to have one of these monogenic disorders. But on the other hand, you can have patients present with IBD in adulthood who actually do have one of these disorders. So don't use this to only rule out or rule in patients, because we've got a number of other things to think about too. So multiple family members being affected, and also if there happens to be consanguinity, autoimmunity, failure to thrive, treatment failures with conventional medications, endocrine concerns, recurrent infections or unexplained fever. That's a really nice tip off, especially if it's far more infections than you might expect, or more severe infections for a potential immunodeficiency disorder. Also, if they have severe perianal disease, macrophage activation syndrome or HLH, obstruction and atresia of the intestines, skin lesions, and dental and hair abnormalities or tumors. So if you're seeing patients that seem to have a number of these features, they might be people that you want to think about ordering a test that would be identifying the genetic cause of some of these very early onset IBD. So here's just a little more information about the panel that we have available through Mayo Clinic Laboratories. It's designed to detect variants in genes that are associated with monogenic inflammatory bowel disease or IBD-like conditions. And so we're mostly talking about this very early onset IBD, but again, it's possible for some cases to not present until adulthood. So they'll usually be presenting very early, especially under age 6 or even under age 2. If you use this panel and detect a monogenic form of IBD or a disorder that's like IBD, then this may allow for a more specific treatment plan, like some of the examples we just discussed. It also can help with predictive testing for at-risk family members, and especially if the patient is going to go on to a hematopoietic stem cell transplantation and thinking about donors for that, a lot of times family members are used. So in that case, it's important to be testing them as well for the known variant once it's identified. This IBDGP, as we call this panel, is a next generation sequencing panel, and we use supplemental Sanger sequencing to fill in some genes that are difficult to detect by next generation sequencing. It includes a total of 51 genes, and we take a variety of different specimen types. So blood being the most common, but we can also accept blood spots, peripheral blood mononuclear cells, cultured fibroblasts, skin biopsies, and just straight up DNA. I'm not going to talk about the specific details here, but this just shows you that we've got a number of different genes in each of the broad categories that I had discussed earlier. And in terms of testing options, the immunologic workup is very important for these patients and complementary to the genetic testing. And the exciting thing is here at Mayo Clinic Laboratories, since we've got a variety of different types of laboratories, not just genetics labs, we have a comprehensive menu of immunologic tests that are also available. And we'd be happy to talk through which tests are most appropriate for your patient at any time. One of the limitations of the IBDGP and many other inflammatory bowel disease genetic panels like this is that if autosomal recessive chronic granulomatous disease is suspected, you might want to order the DHR flow cytometry. So there's one gene, NCF1, that happens to have a common variant that's just not detectable because of the limitations of next generation sequencing. In addition, there are probably other genes that will be found to be associated with very early onset inflammatory bowel disease, because this is such an active area of research. And so it's hard to keep your panel completely up to date with those. So it's something that we'll be updating our panel, and we're constantly watching for the new literature to come out. So if you think that your patient might have a specific form, like you've already done some of the immunologic workup and it's pointing a certain direction, feel free to call at any time so we can make sure that the genes that would be relevant for your patient are on the panel. And if not, talk about other testing options as well. So one thing to think about is a lot of people think, well, why don't we just do exome testing, because then you don't have to worry about these emerging genes and not being able to keep up. Well, the challenge of that is that with the inflammatory bowel disease specific panel, we actually can do supplemental Sanger sequencing for some tricky genes that we know are important for IBD. And if you're doing an exome test, usually some of these genes are just missed at that point in time. So again, if there's this very specific immunodeficiency or other disorder that you're expecting and you want to know the best testing option, just please contact us. The laboratory is always welcoming questions. We like talking about things like this. So in conclusion, inflammatory bowel disease is definitely multifactorial. The environment is playing a role, the microbial milieu is playing a role, immune dysregulation, and definitely some genetics in there too. Multiple therapeutic modalities are available, and TPMT and NUDT15 testing should definitely be performed before you prescribe a thiopurine medication. And if your patient is going to be taking a thiopurine, metabolite monitoring is available once they're already on that therapy to make sure that they're on the best dose for them to avoid toxicity and have efficacy. And specific to the pediatric population, monogenic causes are much more common than they are in adults. These monogenic forms tend to present very early in life, and they're extremely important to diagnose because these patients may not respond to conventional therapy, and they do have specific therapies for some of them depending on the gene. So it's really important to get the right diagnosis, to get the patient started as early as possible on the best therapy so they can get their bowel symptoms under control as quickly as possible. And with that, I would be happy to take any questions. Thank you so much for your attention.
Dr. Moyer, thank you for that very informative presentation. And so at this time, we would like to take questions from the attendees. So if you would like to ask a question, please submit it through the Q&A function on Zoom or use the raise your hand function on your screen, and we'll allow you access to ask your question.
And I see I've already got the first question in here. So the first question is, does Mayo Lab have genetic counselors available to support our patients? Definitely. I think the genetic counselors that we have available are just fantastic. I work very closely with them every single day, and they have deep expertise in not only what test is the best test to order for an individual patient, but they also help with the interpretation of tests. And they're always available for questions from people who are outside of Mayo who may have ordered the test or you're thinking about ordering the test. So we're very lucky to have a lot of genetic counselors available, and they definitely are have deep expertise, like I mentioned before, and I don't think we could do our job without them. So another question actually just came in already too. Do you believe that the inflammatory bowel disease panel is underutilized? I would say that definitely for these monogenic forms, I think this is something that just has really come up in the last maybe 10 years, where we've started to realize that some of these patients presenting really early in life with features of inflammatory bowel disease might actually have a different diagnosis. And so it seems like we don't do as many of these tests as I might have expected. And especially with how important it is to get them onto the right therapy as soon as possible, I think this is something to definitely consider. So again, going back to that young age matters most, I think those are some features to think about when you might want to consider ordering it. And also just in very young patients in general, it's definitely something that could be useful in those situations. But even though it's mostly young patients we're thinking about, don't forget about some patients not presenting until adulthood. So if the adult patient is not responding to therapy as expected or has had many infections while they were younger, it definitely wouldn't be out of the question to order it in an adult as well. Let's see, it looks like a couple more questions are starting to come in here. So what's the diagnostic yield for the IBD panel? That's a really difficult question. I don't have great data on that yet at this point. So I think one of the things that's important is, was the correct test ordered in the first place? Because of the correct tests, I would expect that we would see a reasonable number of hits. But I think with it being a relatively new test, people are still trying to figure out when to order it and for what indications. So every once in a while, we'll see an order come through on an adult patient. And like I've said before, that's not necessarily an incorrect order, but our genetic counselors do a great job of calling the ordering provider to make sure that this was the correct test that they meant to order in those cases. But in general, since we know that inflammatory bowel disease that's presenting in those children under 6, it could be up to 20% or more of those that are actually of a genetic etiology. I would expect the diagnostic rate to be someplace in that neighborhood if we actually collected statistics on that. But again, there are probably also genes we don't know about yet at this point in time. And so maybe over time that'll go up. That's probably something that'd be good to look into some of the statistics on now that we've been offering the panel for a few years. So that's a fantastic question. And hopefully I'll be able to report back more on that later. Let's see. So there's a question about the importance of staying on top of current research when updating the gene panel. How often are the included genes revisited, and what role does the clinical actionability of those genes play in a decision of whether a gene is added or removed? Yes, this is a fantastic question. It's something that I think about all the time. So we're actually in the process right now of updating the panel, and it seems like usually our cadence ends up being roughly every couple of years to be able to add additional genes. And so every time that we go through them again, we revisit every single gene on the panel and think about, okay, now is there any new research that suggests that this gene maybe shouldn't be included? And if not, we will keep those genes. But then we're always looking through the literature to find, well, what are these other emerging genes that are potentially associated with these conditions like early onset inflammatory bowel disease? It's really difficult to know where that threshold should be to include a gene, because maybe there's only one case report out there. So it's only been reported in one patient or one family. Well, it's possible that that's just the first report of it, and there are more to come soon. And if you leave that gene off of your panel, you'll be a little disappointed and have to wait for the next cycle to add it on. But on the flip side, sometimes those end up not actually panning out. So we think about them and we talk about them with the genetic counselor team. And we also often talk with our clinical colleagues who are gastroenterologists seeing patients in clinic, and we tend to make these decisions together. But the exciting thing too is that in the future, we'll be using some different chemistry in the background that will hopefully allow us to add genes more quickly, or to allow people to be able to select some of the genes that they might want that were some of those emerging genes. So I think there's some exciting things that will be coming in the future for that. Let's see. So another question about, do you have a guide for laboratory testing for IBD? Yeah, well, I don't think we have an actual guide per se, but we've got a lot of materials that are available through Mayo Clinic Laboratories, some brochures and things like that. And also the group of sales reps that come and talk to the various laboratories, they're able to help talk through some of when you would use which test. But again, if it's something that you're wondering about, you've just got one phone call away from talking to us in the laboratory, and we're more than happy to talk through these sorts of decisions on an individual patient level, or to talk with you about your approach and what would make the most sense. So there are a lot of different tests available, and so it does get really complicated to think through what would be the best test for each patient. And especially since each patient is very unique, that makes it hard to put together something very comprehensive. But we really enjoy talking about these things with the ordering providers and genetic counselors and anybody out there who would like to hear more and think about what would be best for their patients. And in general, I think one of the questions that came up is just about other laboratories that are offering panels. I think one thing to keep in mind is that, again, there are some genes that are really difficult to detect by next generation sequencing, or sometimes parts of some of the genes that are really difficult. And usually when this happens, it's because there might be two genes that are very similar, or an active gene and something that we call a pseudogene. So it's in there in the DNA, the sequence is almost the same as the gene that we want to look at. And for most people, it's something that you would never really think too much about, but it makes it a little bit more difficult for next generation sequencing, just the way that the chemistry works. And so there are a lot of different laboratories that take different approaches to how to handle things like that. Sometimes they'll just add a disclaimer into the report that says, yes, this is a gene that we know we can't detect because of homology or some other technical challenge. And in other cases, some laboratories, like our laboratory, will look at that gene and say, wow, this is one that's really important for inflammatory bowel disease. It would be unfortunate if we couldn't include this gene because of this homology or this region of this gene. So then we'll take another step to use an additional technology. So for a lot of these genes right now, how we handle that is by using Sanger sequencing, because then that can get around some of the challenges that we have with next generation sequencing. But there are other technologies that can also be used to fill in some of the gaps. So next generation sequencing is really a useful technology, and it's allowed us to test many genes simultaneously, which we couldn't do before in a cost-effective manner. But because of some of those limitations, that's why we still are using some additional methodologies to supplement it. So that'd be something to think about if you're considering testing from a variety of different laboratories and trying to pick which one to utilize is looking through what genes are included on the gene list, how well those genes are covered, are there any gaps or holes because of the technology used? And if it's something that you have questions about, definitely, again, always happy to answer those sorts of questions by just giving us a call in the laboratory. We like to talk about not only how the testing impacts the patient, but we love talking about the details of the tests themselves too. So always happy to do that.
Great. So if there are no further questions today, we would like to thank you, the attendees, and Dr. Moyer for participating in today's presentation. So I hope everyone has a wonderful day, and please feel free to reach out to your sales reps if you have any additional questions. Thank you.